approach that's being integrated, I can't measure. But above all, by people seeing it, you can see healthcare providers doing it on their own, being trained and actually integrating it. So just showing you the amount of patients being seen by the palliative care service. But unfortunately, most of the patients we are still seeing are cancer patients. And this is not linked to the amount of patients that actually require palliative care, especially our cardiac patients who really need earlier palliative care and who are actually only recognized and identified far too late to ensure palliative care is provided to them at an appropriate time. So currently we are seeing only of the patients dying, and we want to see patients long before they are dying, only 27% of those patients who are dying. But if I say to you, what are we doing as a palliative care besides pain and symptom control, diagnostic and prognostic awareness, arranging continuation of care, I will say one of the biggest elements a palliative care team does is ensure the families are spoken to, educated, and followed up and seen as part of the care unit, which becomes a fundamental element of providing palliative care. Having someone in your household with a life-threatening illness has a ripple effect. It affects everybody in that household. So at the moment we have about 100-120 family meetings per month, and this takes quite a lot of time and a lot of skills, but once these skills are taught to healthcare professionals, it makes a massive impact on the way the family interacts with the healthcare team and the way the doctor actually feels they can talk about what is happening. Education is another fundamental element of palliative care integration. We know that undergraduate teaching is probably where it should start, and in most universities in South Africa, undergraduate palliative care teaching is now integrated. We have also developed specialized palliative care integrations teaching, for example, in oncology. But if we reflect on how did it work, why did it work, I will say this has been a good strategy, but it's got fundamental flaws. One of the fundamental flaws are that the consultants were not trained in palliative care. And if palliative care is not brought in at decision making, it doesn't make the impact it should be making. And as one of the registrars said, if the head is not linked with the neck, then there is no integration. So there you are teaching the young healthcare professionals the good work, how it should be done, but it's not integrated with the head. So how can we make sure palliative care is integrated at a much earlier stage? And most probably the best way is to follow an iterative approach. And I'm going to talk to you a little bit about a QI cycle that we did at Krause with patients with pancreatic adenocarcinoma. And at this point, palliative care was integrated at the point of diagnosis. Now, you know, with pancreatic adenocarcinoma, it's usually identified late. These patients have a very poor prognosis, and it should be integrated long before the patient actually even goes to oncology services because of the amount of suffering many of these patients have. And there was consensus among the healthcare professionals who are looking after these patients on a daily basis that this is fundamental. And just by integrating it, we have shown huge improvement on the number of patients that are referred and seen by palliative care services, and also how the palliative care approach actually works. But why did it work? Why did an iterative approach work when integrating palliative care? And it is about sense making. Now, people need to make sense about palliative care before they start practicing it. And if you haven't worked it through in your own head and approached it and actually spoken about it and started understanding how you're actually going to integrate it, people find it very difficult to start a palliative care approach because we do live in a context and work in a context where death is still related to failure. So, one of the great anthropologists said, the trick is to figure out what the devil they think they're up to. So, thinking to yourself, what are you up to when we are doing a very specific thing for a patient? How are we actually improving quality of life for patients and actually ensuring that what we are doing is effective and actually contributing to the patient and the family's care. Now, another element that's also very strong is if you start integrating palliative care at the point of sense making, then we start creating policies that actually reflect it. And Dr. Baudet is sitting here in the audience also with me. So making sure that palliative care then becomes part of normal care. And normalizing the approach is fundamental. So what are the enablers of integrating palliative care? It's an active process. It's not going to happen if we don't do it actively and participate in it and contribute to it actively. We need to be present in the wards. We need to show palliative care. And there needs to be an ultimate non-judgmental, positive regard towards each other. But there are many barriers. The palliative care professionals sometimes too generalist. We need to become more specific, especially at this level when we are doing disease-specific integration. We need to become more outspoken and be better advocates for our patients. People need to understand the value of palliative care. And as I said, value is a complex phenomenon. Because ultimately, the patient and the family need to have a better outcome. And we have very limited studies on long-term outcomes, on palliative care outcomes. So practical steps, if you have to go and integrate palliative care, walk the talk. Make sure you speak about it and figure out how the people who are not integrated make sense of palliative care. Caring for the patient and the family and the healthcare team. Our healthcare professionals are under a lot of moral distress when they don't have the tools to look after suffering. And finally, everybody needs to be educated about palliative care. I can say it now, if you haven't been taught in your undergraduate years, you really need to make time and teach yourself about palliative care. So recommendations, if you are going to integrate, make sure you understand who are your champions already. Whether it is your CEO, whether it's the nurses, whether it's the pharmacist. Palliative care must be included in our governance structures with our monitoring and evaluation and when we are looking at outcomes. We cannot look at outcomes just in the point of looking at mortality. We actually have to look at how were these patients living until they were dying. And there needs to be an urgent need to develop clinical leadership in palliative care. And I hope I'm going to see, I've got a lot of students who are real great leaders in palliative care. And I hope to see many more of them among this audience. Furthermore, we need wider integration into very specific diseases so that the palliative care is integrated at that point of decision making, where we get to a point in the cardiac failure, we know this patient needs a palliative care approach. And finally, we need more research on the costing of palliative care. Thank you.
Thank you very much. We will take a few questions on the two presentations, and then we'll go for the final. Salim?
Good afternoon, Dr. Professor Clark. You know, I am a practicing palliative care Yes. And I just find what you say to be very difficult to do. Very, very difficult. I've worked in a hospital setting. I've worked in an outpatient setting and family care setting and also in a hospice. I have experienced that in a palliative care setting, the cure goals are changed to care goals. Right. Now, in a world where you integrate both cure and care, it's going to be rather difficult because there are patients that need your time, and palliative care means giving them time. So I feel that as much as we like to integrate both care, structures, I just feel that our whole thinking, our whole education process, our whole beings in being a healthcare worker needs to change, because you cannot, in palliative care, you are taught not to prolong life and not to delay death. So I find this very, very difficult as a practice.
Thank you. It is difficult, and it is making sure, firstly, I think when you're working in a palliative care, the doctor firstly mustn't do everything. You need to work in an interdisciplinary team. And I think that the integration in a hospital and the palliative care in a hospital is different from the palliative care going to provide in a hospice. In a hospital setting, there are certain things you need to give to a patient before they go out. They need to understand diagnostic and prognostic awareness. So that's not always just me as a palliative care doctor that does that. As you said, it's the whole system. It is everybody needs to have the same mindset and approach. Fundamentally, everybody's got to sing the same song. And then that care must be provided within a team. And in our team, it's nurses, it's professional nurses, it's auxiliary social workers, making sure you hold that person, making sure that patient goes with a plan for pain and symptom control, and making sure there's continuity of care to perhaps more in-depth care later, but ultimately there's a palliative care plan for that patient upon discharge. I think holding to uncertainties is probably the most difficult for healthcare professionals, when they've got to swing between the curative and the palliative care. And I think that's where the education comes in, and knowing that because we are following a palliative care approach doesn't mean we're not going to offer chemotherapy. It doesn't mean we're not going to offer the radiotherapy or the acute dialysis. This kind of things we need to make sure our healthcare professionals understand.
Thank you very much. Excellent presentation. How successful have you been in getting the administrators to come out and to get the educators, the medical school, learned what curative care? How successful have you been in convincing your colleagues in, say, surgery and other disciplines come to the party?
I have written a book about surgery, but surgeons are very easy to integrate with. But let's start off with managers. As I said, you've got to understand that palliative care needs to be integrated at their sense making. Now, what makes sense to a manager? Complaints. Okay. Once a manager understands that palliative care has a role to play in addressing complaints, because if you look at complaints, a lot of the complaints is about bereavement. If only they did this, if only they did that. I think our process in palliative care has been there where we assisted complex complaints, and they started understanding the role of bereavement and pre-bereavement playing in the acute care of the patients. So following a sense-making approach is very important, and that's the same thing that we started using when we integrated with surgeons. So you know to cut is to cure. So if you can't cut, then what?
I think the last question.
Just more like a comment than anything. I think in this whole integrative process, you got to get a buy-in from the teaching right down to the individual nurse or doctor. Because every person has a different religious background, religious outlook, or not. Somebody believes in taking that, somebody believes in giving to God, and all of that. How do you apply that, or how do you manage that in trying to get an integrated system at the same time getting a whole plan drawn out?
So one of the senior palliative care providers told me, he said one of the most important things you've got to do is you've got to have mutual curiosity. And mutual curiosity means learning more about the other person first before you start integrating palliative care. So you need to start, and you know, when I work with in Cape Town is diverse. When we start working with people from diverse religions or diverse backgrounds, look, palliative care approaches a very personal aspect of care. As you say, it's diverse. So you have to understand how that person actually is viewing their life view. And that helps, because meeting, it's not I'm going to put my approach upon you. I'm going to meet you halfway in making sure we are looking after this patient and this family together. As I said, most people working as healthcare professionals are deeply devoted to the care of their patients.
Okay, last question.
Hi, thank you very much. I enjoyed your talk. More of a comment than a question. As a general practitioner, as the decades have gone by, I've kind of realized that probably one of the most powerful places you can hold is exactly this, talking to families and to patients and explaining when it's difficult. But I've also realized that it's the thing that most doctors like to avoid. So it's about actually saying the difficult words and having the hard conversation. But when you do, families are enormously grateful, and they say, thank you for saying out straight. At least I can understand and I can position. And I've had patients come back to me. I had a patient with pancreatic CA recently, about a year ago, who had a catal was advanced, and she had family, children scattered around the world, and a husband who had difficulty also working overseas, and spoke openly with her and with her one child who was with and said, look, this is not more than 2 or 3 months max. So whatever you can do, you need to do now, and be able to spend whatever time you can before mom actually is unable to have these conversations and enjoy your time. And their gratefulness afterwards is enormous, that thank you for saying it, because the doctors we've been to, the specialists, haven't actually said it. So as difficult as it is for us, these are the most impactful things that we can do. And I think that's the aspect that needs to, people hear the word palliative care, and I think that they just don't want to have anything to do with it, leave it to someone else. But this is actually an essential part of our job and our job description. So we have to, at some point, overcome our own discomfort with it and embrace it.
Thank you. And I just want to say that it's core work. I think families, talking to families is core work of our professional. And part of our working with our senior consultants is that a family meeting, especially when you're dealing with a complex patient, is not held without the registrar in that room. Well, oh yeah, I've got busy, I've got theatre, you will be there. And I laughed when one of the registrars said, after the family meeting, the family walked up, threw his arms back and said, no, I'm going to phone my mom. So this is where you address the development on making understand the importance of looking after the whole person at this stage of their life.
Thank you. I think we have time constraint. Thank you for that. And thanks.